Well, yeah, we're 10 o'clock Australian Eastern Daylight Time on the nose, so let's get started. So, Emily, can you share Emily and Shubo, can you share your screen with the microscope camera and give us a short run through how these usually work?
Yeah, we're just setting up.
Okay, cool. So basically, yeah, the low power pathology says most of it, but yeah, there we go. I'm so excited that this is the first of the open sessions this week. Emily and Shubo and I have been doing these for a little while, and they work really, really well. So there we are. Okay. Can you go to the very, very low power view?
Yeah, just a sec.
Okay. So give us a quick overview, if you can, of how these sessions usually work.
So we normally start on low power.
Yep.
And we
kind of stay there.
Yes, we don't really go very close.
Yeah.
So we describe all the main features and also discuss the pathophysiology and.
Exactly. Yep.
Yeah.
So whatever tissue, whatever sample we're working with, stay at either this overview level or at 5x at the very most, and we'll discuss what we can see and what we can interpret from that low power, and then go on to discuss all of the possible differential diagnoses, the pathophysiology behind it, some gen path, mix in some clin path as well. So, and it's usually great fun.
Hang on a second.
Yeah, that's okay.
So having a few issues.
Yeah, no, that's fine. Yeah. So what we're doing with this first view, you can see Emily and Shubo's camera just there. I'm going to pin you up there. So you can see there's no slide on the stage. So what we're doing, and then I'll shift back to this larger view. What we're doing, we've got the slides sitting on the light source, and then drop the whole stage down so that the condenser brings the overview into focus, so we can get an idea of overall tissue architecture. Right.
Is it okay? It's
yep.
Not that clear right now.
Yeah, there's always a bit of a fisheye effect, but it's pretty good. So rather than grill Emily and Shubo for the entire hour or so, what we'll try and do, we've got lots and lots of people on the on the session, but unmute yourself and jump in. Like whenever we ask questions, the more interactive this is, the better. So we'll have the chat window and everything like that, but I think we should be all right. If you've got an answer or you want to contribute anything, just unmute yourself and pipe up. There's no wrong answers whatsoever here. It's not competitive at all. Everyone's got something to offer. And I guess I should introduce myself quickly too. My name's Patrick, boarded anatomic pathologist, currently working for IDEX in Melbourne, adjunct associate professor with Charles Sturt Uni in New South Wales. Currently also president of the Australian Society for Veterinary Pathology, and involved in a couple of other research and professional projects through similar as well. Great. So starting off, what tissue?
So we should start off, right? So this is a lung. I'd probably put a little bit of history on this. This is a lung from horse, 3-month-old thoroughbred with respiratory distress, non-responsive for treatment for 6 days. The gross pathology was a non-collapsed lung with rib impression. So that's up to the I'll not put anything more. Then we would go for the subgroups.
Yeah, excellent. Now, Emily, Veronique, and Mehmet all picked liver, and looking at this, yeah, absolutely. So maybe, yeah, Madison, unmute yourself. Let us know why you would have picked liver for this one.
I'll jump in here. Yeah, it just looks so dense and kind of, I don't know, just looks liverish, I guess.
Yeah, absolutely.
Yeah.
So so what is it about the architecture of liver that this is suggesting?
Well, to me, it kind of looks like where the bronchioles and the kind of airways are. It almost looks like it's forming like a portal triad kind of like lobular pattern. So it does look quite like liver, especially with the density of the tissue around it. So
yeah, so this part up here where we've possibly got like a large portal artery or something like that, and then a large portal vein underneath. Yeah, I can totally see that. Yeah, absolutely. The fisheye view kind of makes things go fuzzy around the edges a little bit, but absolutely. So so going on from that, since this is so dense and we've got lung with the appearance of liver, or the flavour, if we want to use a food analogy, let's not, I guess, then what does that suggest about the process that's going on? And yeah, anyone jump in, or I'll start. So I can start picking names at random. If you don't want to be put on the spot, then okay, cool. Yeah, Fernanda, yeah, unmute, talk us through. Yep. So we've got a few people going with pneumonia. Okay, can't unmute. Okay, no problem. You should be able to, like I think it's in the top right-hand corner. But yeah, no, pneumonia is a great guess. Oh, not guess, but a great interpretation. So Anna, you able to unmute?
Yeah, sure.
Yeah. So yeah, talk us through the what you're thinking is behind the pneumonia.
Because, well, I thought more bronchointerstitial than just interstitial. I don't see many open airways at all. I mean, you've got that big bronchus in the middle, but the rest is quite dense. So I think it's not only the alveolar walls being affected, but also there's something going on within the spaces that it's totally occluding them with cells. Or whatever, probably cells.
Yeah. So we've got what, 3 different types of pneumonia, basically, don't we?
Yeah.
Yeah.
Interstitial, bronchointerstitial, and bronch.
Exactly. Yep. And the name sort of speaks for itself, doesn't it? You know, where the process is focused in terms of inflammation, and in this case, progressing to pretty much large scale consolidation. Yeah, Mehmet, you said atelectasis. So, so what's atelectasis specifically? Are you able to unmute? Or if anyone else wants to jump in? Yeah, yep, Stephen, collapsed alveoli, exactly. Atelectasis, consolidation, those sort of terms. Good stuff. So, is there much more that we can get from this power?
It seems well, it seems that the alveoli are like maybe filled with like some kind of effusion material, like eosinophilic amorphous material or something. I don't know if it was said before.
Not specifically, no. So that's really good. And so now we're starting to, you know, from this low power view, and we're deliberately spending far more time on it than you would, you know, certainly in an exam context, but even in a regular examination, because from here we've gone from the picture to an overview process to some likely features that we're going to be looking for. And I'm looking for one more thing that we can tell. It's out of focus at the moment, but we can move the slide around on the stage a little bit. Okay, yeah, Penny, we've got distended lymphatic vessels. So yeah, so unmute and talk us through your thinking there.
Sure. So it seems that there is the peribronchial lymphatic vessels and periarterial. It seems they're like seem to be distended with like this amphiphilic material that's it's like off focus now.
Yeah. So can we tell at this power whether they're lymphatic specifically? Can we tell at this power whether they're lymphatic specifically?
Not really. We can't. But the fact that they're like just around the bronchioles or larger airways, and there's no blood retrocytes within them, I would just assume they're lymphatics.
Yeah, and that's a good thought process. Now we'll have to be a little bit cautious and go examining for that specifically, you know, as we get closer, because of course arteries, veins, and lymphatics have you know, different thickness and different resilience of the walls. So some are more or less likely to collapse depending on what's going on. Now, Kaylin, you've asked about thrombosis. Yeah, talk us through that.
I apologize in advance for my English.
All good.
So I think those are blood vessels with thrombosis because I see some smooth muscle, but I'm not very sure at this point with this magnification. Yeah,
exactly. So another thing on the list that we're going to need to examine for, and I can see, yeah, so we definitely do have some blood vessels and arterioles, more specifically, you know, with that thicker wall, and yeah, these large aggregates of red cells in the middle. So so mentally, you know, increasing our magnification power, what would we be looking for specifically if these were thrombi?
I think a fibrin in first instance, and maybe some bacteria in there.
Potentially, yeah, depending on what process is going on. Now, using sort of histology descriptive terms, what's fibrin going to look like? And the reason that I'm asking this specifically is that as we go through the process, we're sort of mentally constructing a description. So what we're driving towards at the end is that first sentence, you know, the overview of what's going on. And then, of course, as we get further through the description, we need specific details that we then follow, you know, with usually the convention is we go, you know, descriptors and then put our interpretation in brackets. So fibrin's our interpretation. What are our specific descriptors that we're looking for?
Would it be all right if I thought about it a little bit? I'm better in Spanish than I am in English. So
yeah,
I'm
absolutely.
Thank you. Appreciate it.
Cool. Yeah, Sahar, alveoli are filled with exudate. Yep, such as purulent material. Yeah, because of the consolidation and things like that. So yeah, so these are specific things we're going to be looking for. Now, the other thing that I was looking for at this power, and it's something with lung, liver, kidney that I have to make a deliberate mental note of to go and check. Otherwise, I tend to forget it unless there's something really florid going on with it. Any guess? The pleura. Yes, exactly. Yep. So what can we tell about the pleura at this power?
Well, I think it looks okay, basically. Yeah, like Pani said.
Yeah, exactly. So at the moment we've got a pneumonia, or we think it's likely to be a pneumonia because of the extent of consolidation. Quite probably bronchointerstitial pneumonia, but we don't have a pleuropneumonia, and there's another feature that we don't have diffuse alveolar damage is one of our differentials for a diffuse process like this. There's a particular feature about the interstitium that we don't have in this that is going to direct us away from particular types of pneumonia and toward others. So has anyone seen, for example, a really nasty Pasteurella multocida pneumonia in a sheep or a cow?
Are you referring to like severe protein-rich edema in interlobular septa? Or
Yes, exactly.
emphysema?
Yep.
Okay.
Yeah.
Well, yeah.
yeah, you're spot on. So what happens there? Because there's so much edema, cattle seem to be particularly good at trying to mop that up too. So the interlobular septa end up getting very wide, and there'll be this strange kind of it's not quite clear space, but it's not quite dense amorphous material, and you can see distended lymphatics in there that are full of fibrin and things like that. And we don't have that going on here. So Shubo and Emily, how about we pop up the slide onto the stage, and we'll hang around at 5x for a bit. And I really like that low power trick, putting the slide on the light source and then adjusting the stage to suit. You won't have time to do that sort of thing in the boards exam, but if you've got large chunks of tissue like brain, liver, lung, kidney, sometimes it's handy too. That can be a really good way of getting your overview picture. If you're not using digital, of course. Cool. So let's start out on the pleura, just because that's where we were a second ago. And yep, pretty boring. So that's firmly directing us towards an interstitial or a bronchointerstitial process. Right. So what microanatomy can we visualize at this power, and more clearly than lower when it looked more like a liver? And feel free to use your clock face as well. So like this will be 12 o'clock, 3 o'clock out this way, 6 and 9, and then variants in between. Or compass points of the arrow if you like. So what have we got in this field that, in terms of our microanatomy?
Well, maybe I talk too much, sorry.
No, it's fine.
Well, we did see some of the structures before in even lower magnification. So at 6, we've got that bronchus.
Yep.
And I imagine it's a bronchus because what is to 9 o'clock from the lumen looks like a cartilage.
Exactly,
plate.
yeah.
And then I would say the other smaller tubular structures. Sorry, I'm Spanish, so I sometimes struggle with my English.
Yeah, no, you're doing great.
The other smaller tubular structures that are just like at 12 of the bronchus and in like forming, I would say like straight line type of thing would be, my guess would be that they're probably bronchioli.
Yes,
and,
exactly.
Well, the big blood vessels that the other colleague mentioned before, this look more like arterioles or arteries.
Yeah, exactly. Good. So now this is a slide that we will be limited if we stick at this view for forever and ever. So we will end up going in a little bit closer. But first, I want to narrow down some particular features that we're going to go in closer and confirm. So are there any, I guess, there are some processes, now this was tissue from a foal, wasn't it, Shubo?
Yep.
Yeah, so there are some processes that we can rule out straight away, aren't there?
Yep.
Yeah. So yeah. So everyone, what kind of things can we rule out, or put lower down on the list at this power, or from what we've seen so far?
Like neoplasia, you probably would maybe start ruling that one out.
Yes, exactly. A really, really important infectious cause of pneumonia in foals.
Rhodococcus echi.
Mm-hmm. So how is Rhodococcus going to look different from what we've seen here?
It looks, I don't remember exactly, but I think like a bronchopneumonia.
Mm-hmm. Yep. Yeah, embolic pattern. Yep. So what is it, Haley or Madison? Yeah, unmute and talk us through what's an embolic pattern going to look like.
So Rhodococcus doesn't tend to have that diffuse appearance with the lung equally affected, from what I remember. It's
exactly, yeah.
Abscesses forming because it's coming hematogenously to the lungs rather than an inhaled thing. So you get, yeah, the big areas that are affected with more normal lung in between.
Yep, yep. Yeah, exactly. So we're going to have patches of normal kind of chicken wire lung, and then now, what's a distribution going to be for Rhodococcus?
Multifocal.
Yeah, multifocal or multifocal to
coalescing.
Coalescing, yeah, exactly. So that in itself, and the video playback on these sometimes is going to look a little bit weird because we're going to be staring at a thing like this and just imagining something else. So I'm hoping you can picture. Like, I'm a very visual person, but I'm hoping you can all picture a similar low power view of a Rhodococcus lung where we've got that, you know, sort of normal chicken wiry stuff, and then these multifocal to coalescing nodules or abscesses. So talk us through what our key features of, say, a Rhodococcus abscess are going to be.
I mean, being an abscess, it's going to be mainly neutrophils in the middle and a lot of necrosis and cell death, and so a lot of pink stuff at low power, I guess.
Yeah.
And then depending how long-standing it's been, you may get some more organisation around the edge, some more macrophages, some fibrous tissue, and a bit more structure to it around the edges. Yeah,
yeah, exactly. Now, with that, the reason that I'm focusing on this a little bit is that this description for an abscess or a granuloma or a nodule, if we've got, say, granulomatous inflammation, with epithelioid macrophages or something like that, this kind of something in the middle surrounded by something else surrounded by something else is one of our canned descriptions. So as soon as you see that pattern, you can go, oh, right, this is my canned abscess description. These are the particular things I'm looking for, confirm, and just write them straight out. It saves a heap of time. So let's put some structure around the descriptive terms for what you've just talked us through. So in the middle, you mentioned neutrophils. Degenerate or non-degenerate?
Probably a mixture of both. Probably non-degenerate in the middle. Yep.
What else are we going to have? So you mentioned fibrin. So what are some descriptors that we'd put in a report for fibrin?
So kind of eosinophilic, hyaline material.
Yeah, hyaline. Sometimes it's going to be, and everyone else, like chuck some descriptors out at us. That's what we're aiming for. We're building up a mental picture with jargon and terminology. Fibrillar, yes. Sometimes it'll be amorphous. If it's a little bit indistinct. What else? And so now we're veering well away from our current lung and getting into our abscess. What else is going to be mixed in with that central necrotic material? Good, yeah, amorphous, anuclear eosinophilic material. Yep, love that, Anna.
Calcification.
Potentially calcification, yeah. So that we'll kind of stick a pin in that because that suggests specific processes. if it's been going on long enough for calcification to happen, or if it's more commonly associated with particular organisms. Yeah. So yeah, Penny. Now, there's one other thing, if we've got, I'm just sticking around on the lytic necrosis for a second, then we'll come back to the caseous necrosis. If we've got lytic necrosis going on, then what else are we going to have mixed in with the degenerate neutrophils and the amorphous eosinophilic material? Cellular debris, yep. And so it can be cellular, it can be, now we're not, I guess the nuclear debris is going to be mixed in with the fibrin and all the pink stuff. But karyorrhactic debris as well, I like to use that one. Yeah, so intralesional cocci, we'll come back to that because that's one of our specific confirmatory descriptors. So we've described our way through our central, pink mess of material in our abscess. Then that's going to be surrounded by what?
Fibrous connective tissue.
Yeah, neutrophils and before we get to the connective tissue, there'll be a little bit of that. Lymphocytes, macrophages, and then on to our fibrous capsules. So we've sort of generally, I kind of structure my abscess description with a central thing surrounded by a thing surrounded by another thing. So in this case, it's our necrotic material, and we've got all our descriptors for that. Then lymphocytes and macrophages, and the macrophages might be hypertrophic. Probably not going to describe them as epithelioid specifically for a rhodococcus abscess. And then a fibrous capsule. And so Sahar, throw us some descriptors for what the fibrous capsule is going to look like. Are you able to unmute?
Sorry for my English.
Oh, no, not at all. Yeah, no apologies necessary. Yeah, you're very welcome. Okay. And thanks for contributing.
Oh, thank you for you. It would be fibers of pink color,
yes.
Connective tissue. Yes.
Yeah. So, so specifically, thinking through, and this is a little bit more GenPath. So, connective tissue or mesenchymal tissue is going to be a mixture of cells and matrix, isn't it?
Yes, it would be connective tissue of fibroblasts and some collagen fibers. Yes.
Yes, exactly. Yep. So those are the specific descriptors that we're looking for. If we're doing a really, really detailed, this is our abscess, then our final layer is kind of further surrounded by, if it's really mature, then it's going to be fibrocytes with fewer fibroblasts and collagen fibers. So yeah, perfect. So we've successfully described the thing that's not here. I love it. Yeah, and then maturing granulation tissue as well. Yeah, absolutely. Cool. So that's really, really good. So now that we've got a good picture of our rhodococcus lung, we're confident that that's not what this is. Let's go about, describing our way through some of this while we're still at this power. And people have mentioned already, this is looking like an interstitial or a bronchointerstitial pneumonia. What particular features are you going to be looking for, and use specific descriptive terms? What specific features are you going to be looking for if this were an interstitial pneumonia?
Thickening of the septa.
Mm-hmm. Yep, thickening of the septa. Yeah, and Anna said exudates and inflammatory infiltrates as well. Yep. So let's start from, and again, we're mentally structuring our approach to description and our approach to examination. Yep, 3 months old. Was the age of the foal that we've got here. So what's our so someone run us through unmute and run us through what microanatomic structures we're going to mentally or actually examine in some sort of order. The order doesn't matter as much at this point, but yeah. So run us through the microanatomy of what we're working through.
Should I?
Yeah, go for it.
If I go for test just a subgross, this is also still subgross.
Yeah, absolutely.
The lung parenchyma diffusely appear highly cellular and consolidated.
Yep. So that's our overall impression. But I'm looking. So what I'm getting at here is that, and yeah, we're going right back to the very basics of histologic examination. In every tissue, there are compartments, and in every compartment, there are subcompartments. So to do a thorough examination, you go through and mentally check off each one of those. And in certain organs, you can do an outside-in approach or an inside-out, and you might change that depending on what process is going on in front of you, or you know, what the most likely pathologic process is. In this case, let's start from inside out and sort of list our compartments from the innermost part of the parenchyma out through to the edge of the lung.
So in that case, starting from the alveoli.
Exactly. Yep. So the alveolar lumen, and then. So,
yeah, I would say that at least 50 more, at least 70%.
So at the moment, we're just looking for a list of things to look at. Yeah, we don't have to describe the features just yet.
All right.
Yeah, you're all good.
Alveolar lumen, we need to look at whether there is any exudate or not, or whether there is any substance in there or not. Then we go to the alveolar lining.
Yes.
So what it is made up of, whether it's type 1 pneumocyte or type 2 pneumocyte.
Yep, brilliant.
Or club cells or whatever. Then
I love that. Yeah, well done.
And then we are moving towards how many layers of these epithelium cells has been constructing the alveolar lining. So it could be one single layer that is perfectly normal, but if it gets like more than one is absolutely abnormal. So in this, I don't want to say about that, but it can be multiple layers. Then we go see whether there are infiltration of any inflammatory cells, particularly within the alveolar septa, and what comes associated with this.
Yeah.
Also moving forward, we would look after that to the lymphatics.
Yes.
And whether it is dilated or not, whether it has any fibrin or not, whether it has any evidence of edema or inflammation.
Yep.
Moving forward to that, after that, we would go for secondary or terminal bronchiole, then parabronchioles or bronchi. So in the bronchioles, we would look first at the lumen, whether it has anything in there. It's presumably mucus, fibrin, or exudates.
Yep.
Then in the we would look for pseudostratified squamous epithelium, whether it has the cilia intact or there is some metaplasia happen or not.
Cool.
Then moving inward in the mucosa and submucosa. Submucosa and mucosa of the bronchi and bronchioles should be fairly intact unless it has been edema or infiltration of inflammatory cells. In many cases, we see a lot of macrophages infiltrate with many of the disease process, and also metaplasia happens in the epithelium. So these layers should be considered. And then we look for surrounding tissue of the bronchi and bronchioles. Look for nodular hyperplasia of lymphocytes, if there is any, or is there any specific pattern. Then also, then we need to move towards the blood vessels. So look at the tunica media and particularly tunica media, whether it has been infiltrated with some sort of inflammatory cells or it has been discontinued. We need to look carefully if there is any specific endothelium damage or not. So we are looking actually for vasculitis if there is any. And then I would go for the pleural surface.
And similar kind of things in the pleural surface. The connective
if there
tissue.
Is any infiltration or granulation tissue formation, thickening, how much thickening, fibrin deposition or not, inflammatory cell, what kind, that sort of thing.
Yeah, that was the most wonderfully detailed description ever. Yeah, you rocked that. That's awesome. Cool. So this kind of process is what's going on in their heads in a fraction of a second when we first see the slide, and we're automatically including or chucking out possibilities based on that. So we'll stick around at this power just a fraction longer, and then in terms of this particular slide, we've probably squeezed as much as we can out at this power, and we'll actually break our rule on the very first session and go down a little bit closer. So what using descriptors, everyone pipe up, what would you be expecting to see within the alveolar lumen? Neutrophilic exudate, yep. So we'll get a mixture of, eosinophilic material, exactly. Macrophages, macrophages are a good one. So ordinarily, do we have macrophages within the alveoli?
It can, sometimes it can spill over.
Yeah, exactly. So what we'd be looking for within the lumen here is not so much whether or not they're there, but how many and what sort of state they're in, whether they're hypertrophic and phagocytosing material or whether they're just kind of bystanders and it's primarily a neutrophilic process. Viviana, can you unmute yourself and talk us through hyaline membranes? That's a really, really important thing when we're looking at a lung like this.
Was just thinking of, when there is complete disruption of the air-blood barrier, and we get leakage of, plasma proteins, and they mix with the cellular, debris that is within the alveolar spaces, and that just forms the membranes covering, what's, I guess, been disrupted.
Yes, that's a perfect pathophysiologic description. Absolutely. So why is it so important in this particular case that we would be looking for hyaline membranes or not?
I guess it may contribute to your final etiological diagnosis.
Yeah, yep. So, and what I'm getting at, hyaline membranes, do you see a prognosis potentially? Yeah, you're absolutely right, Stephen. And certainly, if the entire lung looks like this, then we can see why the part of the animals ended up on our microscope stage. Hyaline membranes suggest the pathophysiology that you've described suggest a particular type of process. So are they more commonly associated with an acute lung or chronic pneumonia? Diffuse alveolar damage, and acute, absolutely, Penny. Acute. So what processes would we be thinking of? What underlying causes would we be thinking of if there were hyaline membranes all through the lung? Type 1 pneumocyte damage, yep, so that's part of the pathophysiology. So what can damage type 1 pneumocytes?
A lot of things.
Yeah,
Viral,
lots of things, yep. Viral, yes.
Bacterial.
Yep. So check out some specific viruses.
Herpes virus.
Herpes, yes.
I'm more into cows and sheep, sorry. But,
no, absolutely, yeah. And this is one of the important things. As a side note, doing lots of cows and sheep will stand you in really good stead in terms of descriptive stuff for boards and in general, because yeah, the path is so interesting. Yeah, the other thing is that common things occur commonly across species. So you know, it's why we're so darn good at what we do, because we can look at a tissue in a species that we've never seen before, and if there is type 1 pneumocyte damage with multinucleated giant cells and eosinophilic intranuclear inclusions with peripheralized chromatin, then we'll go, oh, that could be a herpes virus. Yep, respiratory syncytial virus, yep, type of herpes virus. Couple of others. If this were a dog and there was type 1 pneumocyte damage.
Influenza?
Influenza, yes, absolutely. And influenza is one of your classic. So what we're getting at now is a mental picture of an acute lung. And that term acute lung is kind of a reserved term for certain processes, one of which is infectious, and we've had toxins mentioned as well. That's another major cause of an acute lung. So viral infections, yeah, influenza is kind of our model for viral acute lung, because it specifically targets the alveolar type 1 pneumocytes, and so there's lysis, and then all the pathophysiology that we've talked through before. Yeah, herpes virus, absolutely. Another one in a dog, which I guess is more of a chronic, but you know, you can get some hyaline membranes with it. Adenovirus, yeah. One that's more common in areas without much vaccination. Distemper, yes, exactly. Yeah, good. So talking through all of this is building up our mental list of potential etiologies, which and there'll be particular features with each of those. So we've talked through the herpes one. What else could do multinucleated giant cells in a lung?
Tuberculosis and yeah, TB.
Yep.
And fungal.
Fungal, yep.
Parasites.
Yep, parasites. Distemper will do it as well. Yeah, mycobacterium, fungal. Yeah, good. So each one of those should send us down pneumoconiosis. Yeah, that's a good one. Each of these will send us down a different path, because apart from the viral causes, most of these other causes will have a different subgross picture. So, you know, fungal pneumonia should look a bit more like a rotococcal pneumonia, you know, multifocal decoalescing granulomas. Yeah, so we've talked through viral causes, bacterial causes of type 1 lung. Now, of a type 1, sorry, not type 1, of an acute lung. What's unique about the pathophysiology of that that's, I guess, specific to bacteria, but it's not, what I'm getting at is it's more related to toxic rather than anything else.
Are you referring to the mechanism of action of each independent bacteria? Like ones are targeting more, like they have leucoclastic toxins and others don't?
Yeah, that kind of thing. And I guess talking in more general terms than that, so endotoxin. Yep, endotoxin specifically will damage you know, vascular endothelium and will damage respiratory epithelium. So you know, and that's where it starts to get really complicated, because a type 1 lung, an acute lung might be due to endotoxic damage to the alveolar epithelium, the type 1 pneumocytes. But then, of course, you've got all these other systemic complications with vasculitis and multi-organ dysfunction and things like that. Now, if this were a cow with an acute lung, what's one of our major differentials?
Pastorella could be one, Mutocida.
Yes, yeah, because that's got similar toxins.
Manhemia, but that's not the morphology that Manhemia normally follows.
Exactly, yeah. So if this was Manhemia or Pastorella, we'd be expecting multifocal lytic necrosis and those great big expanded alveolar septa with lots of edema and things like that. Yeah, Penny, 3-methylindole, exactly. So can someone talk us through the pathophysiology of 3-methylindole intoxication?
Well, I was so 3-methylindole is normally due to ruminal acidosis. You've got the pass of this substance through blood into and gets onto the lung. But I hadn't, well, my understanding is that normally you would see just an interstitial pneumonia, wouldn't you?
Yes, yep. So you wouldn't expect to see it quite so consolidated like this. It's because it's kind of a pure interstitial process, but from the point of view that the alveolar epithelium, to my mind, is included in the interstitium. So we've got that lining, and then the actual gap between the alveoli itself, with a connective tissue and blood vessels. And Veronique, I'd love that list of differentials. We'll get back to that. So basically the plants with 3-methylindole are ingested, then that's circulates in the bloodstream, crosses the blood-lung barrier, where it's metabolized by, now someone's going to have to check me on this one. Yeah, here we go. Yep, Penny's got it. So ingestion of L-tryptophan, that's it. Then the rumen bacteria converts that to 3-methylindole. So Penny, were you having trouble unmuting before? That was right, wasn't it? Before I steal your thunder and talk through all of that.
Oh no, I didn't want to talk.
Yeah, well, if you want to stay quiet, then I can talk through that for you. But if you'd like to share, then that would be great.
Sure. So basically, normally when cows or cattle over 1 year of age are transferred to a lush or a new pasture, where you have lush greens reaching L-tryptophan, they ingested, and the rumen, the bacteria converted to 3-methylindole, which is not toxic and is absorbed via the rumen and goes into the bloodstreams to the lung, where it goes to the club cells or Clara cells, and it's converted by the P450 enzymes into the toxic metabolites, which I'm sorry, I don't remember by heart. And that causes type 1 pneumocyte damage and alveolar damage, basically, and bronchiolar damage too.
Yes, exactly. Yep, perfect. Well done. And I think, even for boards level, if you got that follow-up question of, what's the pathophysiology, you've got your descriptive part of the slide, and then a follow-up question, describe the pathophysiology. I think that should get you, all or most of the points. I don't know that you need to know the specific metabolites, but say, for example, if there'd been a paper on it recently or something like that, then it might be in the multi-choice questions that you have to know the specific metabolites. But yeah, that's excellent. So we're thinking this particular lung is probably not our classic acute lung. There's possibly a little more chronicity. So and just backing up a little bit. So yeah, Veronique, all of those differentials that you listed, they can all, BRSV, influenza, IBR, they can all do an acute interstitial pneumonia. Cattle, I guess we don't tend to see, unless it's something like 3-methylindole, where they go down very quickly. We don't tend to see acute lung in cattle just because of the nature of the production system, and they tend to be quite stoic. So they'll keep going on until things are a little bit more chronic, and then that's when we get to see the histology. But yeah, and of course BRSV, IBR, they'll do multinucleated giant cells as well, or multinucleated cells and syncytia. So we've probably hung around at this power long enough. How about we go in one more, because we've talked through what we'd expect to see in the alveolar lumen, and whether or not we'd be looking for for hyaline membranes and things associated with an acute lung. And then we've got an idea of some of the things that we'd be looking for within the interstitium too. That's primarily where we're focused. So what are we seeing at this power?
Should I move a little bit further to show up?
Yep. Yeah, okay. So what can we see within the lumen?
There seems to be like a granular material. I wonder if it's like a fungal organism in there.
Yeah, okay. Because the tincture or the intensity of the staining changes a little bit from one location to another, doesn't it? Yeah, Anna, I love that description. That's brilliant. Eosinophilic homogeneous material within alveolar lumens. It's excellent. What can we see about the interstitia or the septa at this power?
Moderately thickened.
Yeah, yeah. But still not kind of looking for what I'm. Yeah, in some places they're ruptured. So that leads us down a. We won't go too far down that path. You know, if we're seeing ruptured or disrupted alveolar septa, that leads us down another path. But what we'll end up doing over these sessions is coming at the same organ in a bunch of different ways depending on what the process is. So things like lungs and kidneys we'll do in multiple different ways because there's so many compartments to describe. They're great descriptive slides. So there'll be certain things that we'll skip over in some, but we'll cover in others. And I guess what I'm getting at with the question about the interstitium is we're still thinking this is more likely an acute process, yes? Or acute to, acute to subacute. And what I'm getting at is kind of how far along do we think it is, and what features within the interstitium would kind of help us to distinguish that. Pneumocyte. Perfect. That's an excellent question. So is there type 2 pneumocyte hyperplasia? Yep. What's our process behind that?
It's a compensatory process.
Yeah.
Basically.
Yep.
Because if your type 1 type 1 pneumocytes damage, then type 2 pneumocyte has to fill up the endothelium so that it's not leaks. It doesn't leak anymore.
Yep. So, exactly. And so epithelium in general is a covering and lining cell. So it's going to try and repair the defect as best it can. Now, of course, specialized epithelium in the lung, the type 1 pneumocytes make themselves as thin and as flat as possible to facilitate gas transfer. But if there's damage, then they just have to patch the defect as best they can. So type 2 pneumocytes, and eventually there's maturation. But if we've got a severe diffuse process, then type 2 pneumocyte hyperplasia is a good histologic indicator of where we are along the time spectrum. but might actually further impair the animal's respiratory function in the short term. Yeah, smooth muscle hypertrophy. Okay. So what does that imply? Contraction? Yeah. Or I guess in terms of chronicity and respiratory effort, what does that imply?
Hypertension?
Yeah, so subacute to chronic process. Yeah, yeah, we absolutely can see it with hypertension. Obstructive pulmonary disease, yeah, associated with increased respiratory effort. Yeah, absolutely. Cool. So now I'm just checking the time. We're at 5 to 11. So we'll try and wrap this up sort of soonish so that everyone can get away on time. But yeah, so at the moment we're looking at probably a subacute interstitial pneumonia. Let's dive down and have a look at a few more things, see if we can nail down a more likely etiology.
What?
Yeah.
Okay, good stuff. Yep. So here's we definitely have a process focused on the alveoli and the interstitium. We'll want to check some of the some of the bronchioles. So what have we got inside these alveoli?
These are two different substances actually mixed up. So one is amorphous hyalinized eosinophilic material.
Yep.
And a little stench of fibrin laces. So I would say it's both surfactant as well as the edema fluid.
Yeah,
so
cool.
It's a mixture of these two because this is not entirely homogeneous. So I can see here there is some more, a little dense material, which I would say is surfactant, and it's been floating around with the mixture of the edema fluid.
Yeah, yep. So there'll naturally be a mix of those two types, and the appearance of the fibrin is going to depend on how long it's been there, and yeah, when it's because it's going to polymerize when it mixes with air. So yeah, how much is there, how long it's been there, all of that. Do we have do we use the term fibrin-rich edema? Oh, I wouldn't, because if we're talking about fibrin, yeah, a precursor is fibrinogen, then that's cleaved and polymerizes to form fibrin. So if it's still edema, I certainly use high protein edema when it's more hyaline like that, and it appears more fluid than more solid. But yeah, fibrin I would reserve for when it's actually undergone that change and polymerized and started to clump and become more chunky, if I'm using a very, very bad descriptive term. Yeah, slough cells in the alveolar lumen as well. Yeah, cool. Do we have hyaline membranes along here?
Not really, not much.
It's hard to tell. They're just so full of stuff. Like at 3 o'clock, there's a little bit that sort of looks like it, but there's just so much stuff in them. It's really quite hard to tell. And we've got expansion of the septa with similar in inflammatory cells and things like that.
I would say this is a continuous lining would be cuboidal kind of cells.
Yeah, so do we have type 2 pneumocyte hyperplasia through here?
I would say so.
Can we identify that specifically? because it can be really hard with a lung like this when there's just so much going on.
It's according to Job and Kennedy, it's not possible under a H&E to differentiate pneumocyte 2 and the macrophages.
Yep, and I would really struggle to do that in a lung that looks like this.
But do you see my cursor?
Yep.
But if, again, by definition, if it is a continuous base lining of cuboidal cell, not a mixture of squamous or simple squamous cell, if it is a continuous lining made up of cuboidal looking cells, it has this component of type 2 hyperplasia because it's been repairing the endothelial lining. And as you can see here, these are probably macrophages. So I don't know, it's tough actually.
Yeah, it's hard. So everyone, what's our kind of classic appearance for type 2 pneumocyte hyperplasia? And what I'm getting at is they often look kind of, palisading cuboidal cells. Yeah, exactly. So we can't see that specifically here, but yeah, palisading cuboidal cells is what we're looking at, or that kind of cobblestone street appearance.
Okay.
Great. So let's have a quick look at the bronchioles, and then we might start to wrap it up. Yep.
I'd go a little bit down. These are probably artifacts.
The separation of the I agree.
These are entirely clear. Most of the smaller bronchioles.
So
clear.
Yep. So an interpretation is going to vary, pathologist to pathologist, but I would be thinking this is principally an interstitial rather than a bronchointerstitial, because so everyone, what kind of features would we be looking at to differentiate a bronchointerstitial from an interstitial pneumonia?
Necrosis or damage to the bronchiolar epithelials.
Yeah, exactly. Yep. And you kind of want to see inflammatory cells migrating across, don't you, and actually contributing to that process, and then with the necrosis of the epithelial cells. Is it enough just to have necrotic material and inflammatory cells within the lumen? No, exactly. Yep. Because we want to see that the process is actually targeting the bronchi and the bronchioles to call it a bronchointerstitial pneumonia. Cool. So we've got an interstitial pneumonia in a 3-month-old horse. What are some of our differentials?
Could be herpes 4.
Herpes virus, yeah.
And psittacosis. Maybe.
Ah, interesting. I've seen. That is an interesting one, because I don't know that I've seen a chlamydia psittacine pneumonia in a horse before. Have you seen one?
Oh, we see.
Yeah, cool. So are these foals that have usually been associated with like a difficult birth, and then have gone on to like a chlamydia psittacine associated, not abortion obviously, but an infection in utero, and have then gone on to develop pneumonia?
Yes, you might remember when you've been here.
Yeah.
So we had before you, this panels had a lot of dead foals, and the whole PDL been infected with chlamydia.
Yep.
So this is common in this particular part.
Yeah. Okay. Cool. So for everyone else,
foal did have a difficult birth, and it had chronic GI disease when it was, I know, the first 6 weeks of its life, and then this was 3 months.
Cool.
Later. Yeah.
Yep.
But I would break the lab work. It was negative on initial testing.
Okay. Good. Yeah, and Viviana, arterivirus, pneumocystis, because if we were looking at low power, and I'm not quite sure how common pneumocystis is in horses. I've seen it in like lab animal species and primates, and it's dogs, cats certainly. But yeah, that kind of in some area, in some of the alveoli, it kind of looks grey. So yeah, absolutely, and slightly granular. How about bacterial causes?
I don't know. Gram-negative.
Would we see rhodococcus is a good thought. Would we see a rhodococcus lung looking like this?
This would be more focal, multifocal, polycystic.
Yeah, typically, yep. Actinobacillus, Klebsiella, yep, those are really good. Strep equi, yep, that's one of the ones we'd want to rule out. Yeah, go ahead.
I guess I haven't shown the other slide I got with this case.
Oh yeah.
There's a twist here.
Nice. Okay, put it up. Put us out of our misery. Oh, there we go. Oh, I love it.
But this was multifocal, and the amount of nodulation in the lung grossly was not really great.
Yeah.
So we initially thought that it is definitely some sort of primary infection happening. Then the secondary rhodococcus came up.
Right.
And the test so far isn't positive for chlamydia. The next differential is herpes virus 4 that we are thinking it might be.
Yep.
There is not so much of evidence of other toxin around, but so rhodococcus has been positive in culture. So I would say there's two processes going together. But
yeah, cool.
The amount of like lymphoid depletion and other lymphadenitis you'd see, and in rhodococcus also with the amount of nodular changes in the lung, it would be much more severe, I would say.
Yep.
That causes if it was primary, the cause.
Yeah.
Just that one foci we got here.
And Katie and Viviana, strep zoo epidemicus, E. coli, enterotoxemia, love those. Cool. Yeah, so that very different picture on that second slide. I love it.
Yes,
cool.
Some atelectasis, emphysema also somewhere, some places.
Okay, that's great. Cool. Well, we might wrap it up there for today then. Excellent descriptive slide. Thanks so much.
Right.
And of course, everyone else that that's on the call, feel free to suggest cases. Like all we need is either a microscope with a camera, and whoever's suggested the case can host it and run live, or a digital slide would be fine, or even pictures. If you've got an overview and then a couple of subgrowths, then we can talk through that equally as well. So if you've got suggestions for cases, I'll post up again in the CL Davis forum and other places. So yeah, send us through suggestions of cases, and we'll line up some some people to present for the next sessions. And thank you all for your participation and for joining. It's been fantastic.
Thanks, Beth.
Thank you.
Cool. Thanks so much.
Thanks, everyone.
Yep, see you.
Thanks, everyone. See you next time.
Bye.
Bye. Enjoy.